Okay, just loading a little more. Okay, and we are live. Good morning, web shadowers. I hope you had a great weekend. Thank you for joining our session today. Today we have the pleasure of hosting Dr. Dana Elborno again. She's an OB/GYN. As always, please remember that the Google form will be posted in the comments and on our Instagram bio at the end. With that being said, Dr. Elborno, you can share your screen and start whenever you're ready.
Hi, everybody. I'm Dr. Dana Elborno, and we have a very special guest with us today. This is my French bulldog, Vinny. I just wanted to bring him on this morning to brighten your Monday mornings, and then I'll share my screen. Today, we're talking about polycystic ovarian syndrome and other syndromes of hyperandrogenism in adolescents. And let me share this. And share this. And so I'll just go back to the beginning because for some reason it started at the end. Okay, so I'll just do a quick intro for web shadowers who have not attended with me before. So I am an obstetrician and gynecologist. I also completed a fellowship in pediatric and adolescent gynecology, and I'm currently working at Northwestern Medicine in the Chicago suburbs. I do practice as an OB/GYN generalist, meaning I do obstetrics and adult gynecology as well. I just have a special interest and passion in seeing and treating patients around adolescence and in pubertal or in pediatric populations rather. So I wanted to start with a little bit of an intro to some of the important landmarks of puberty and progression into puberty and menarche, and to discuss what a normal pubertal progression looks like, to discuss what a normal period looks like in the perimenarchal period, and then to discuss a case about when it's abnormal. So puberty is a series of events, both physiologic and neuroendocrine events, in which a person develops secondary sexual characteristics. And for someone who has XX chromosomes and is born assigned female, they have the ability to ovulate and menstruate. It takes a 2 to 4 year span, excuse for my typos, starting between age 8 to 13. For the majority of patients, about 98.8% of patients will start their pubertal progression between ages 8 to 13. And a normal pubertal progression starts with telarchy, which is the start of breast development. Adrenarche and gonadarche are not really clinical things that we can see, but they're rather neuroendocrine events. Adrenarche being the development of the zona reticularis in the adrenal gland, which allows your adrenal gland to make male-type hormones like dihydroandrostenedione, sulfate, and androstenedione. And then gonadarche is the turning on of the HPG axis, also known as the hypothalamic pituitary gonadal axis, which turns on the communication between your hypothalamus, your pituitary, and your ovaries, allowing them to communicate in a cyclic way and allow the production of estrogens from the ovaries. Pubarchy is the clinical finding of hair in the pubic region and under the arms, and then the growth spurt occurs, and then the end landmark or the end time point for puberty is when the menstrual period starts, also known as menarche. So there's a mnemonic to help you remember this, which is, now I'm forgetting it, but essentially it's you have your breast development first, then pubes, then you grow, and then you bleed. And we mark all of these time points with Tanner staging. So Tanner stage 1 is nothing. There's no such thing as Tanner stage 0. Tanner stage 1 is when there's no breast development, and Tanner stage 1 for pubic hair is when there's no pubic hair. And then for Tanner stage 2, that's when you have breast buds, which just means that there's a small elevation of breast tissue right under the areola. And Tanner stage 2 for pubic hair is when there's sparse growth of kind of longer, slightly pigmented, but downy hair. There's nothing that's like curled or thick. Tanner stage 3 is when there's further enlargement of the breast bud and it extends beyond the areola. Tanner stage 3 for pubic hair is when there's darker, coarser, more curled hair, and it's just beginning to spread across the pubic region, but there's still no hair on the inner thighs. Tanner stage 4 for breast development is when there's a secondary mound of breast tissue. So beneath the mound of breast tissue, just on and beyond the areola, there's now a secondary mound of breast tissue. And then Tanner stage 4 for pubic hair is really more like adult hair, but it extends up to the inner thigh and still does not extend beyond the inner thigh. Tanner stage 5 is really mature breast and pubic hair development. So Tanner stage 5 is when there's a normal contour to the breast tissue. There's no longer a mound of tissue on the areola, and then beneath it, it's really just a normal curvature to the breast tissue. And you can see that more significantly in the side view in the pictures. And then Tanner stage 5 for pubic hair is adult type and quantity of pubic hair, and it has spread to the nearby thigh areas. Now, to discuss gynecology, you'll never get through a GYN lecture without seeing this image. You guys will see it a million times in med school, and if you do an OB/GYN residency, a million times then. And if you go into REI or pediatric gynecology, you'll see it a million more times. So essentially, day 0 of the menstrual cycle, the start of a new menstrual cycle is day 1 of a menstrual cycle, the first day of a menstrual cycle is the first day that there's bleeding. Ignore the fact that there's a 0 down here. We don't really talk about a day 0 of a menstrual cycle. So day 1 is the first day of bleeding. And essentially this occurs because there's very little follicular development in the ovaries, and the uterine lining is starting to shed from the previous cycle. So at the beginning of a menstrual cycle, there's pulsatile GnRH being released from the hypothalamus. GnRH is gonadotropin releasing hormone, which sparks the release of FSH and LH from the pituitary gland, the anterior pituitary gland. FSH is follicle stimulating hormone, and LH is luteinizing hormone. FSH, as per its name would suggest, stimulates the follicles in the ovaries. The follicles in the ovaries are made of both granulosa cells and theca cells. Granulosa cells respond to FSH better, and they are what release the aromatizing hormone, which turns nearby androgens into estrogens. Luteinizing hormone acts more on theca cells being responsible for secreting more androgens like testosterone, dihydroandrostenedione, androstenedione, and the like. Androgens usually get aromatized to estrogen in the granulosa cells. So this is a very important thing to remember, that it's a 2-cell process to make estrogen from the ovaries, and requires both androgens being secreted from the theca cells under the effect of LH, and those androgens getting aromatized to estrogen in the nearby granulosa cells under the effect of FSH. And usually in the beginning of the menstrual cycle, also called the follicular phase, there is pulsatile GnRH from the hypothalamus, which leads to the secretion of both FSH and LH, which work together to act on both the granulosa cells and the theca cells to secrete estrogen. So you can see here that there's the green line and the red line for both FSH and LH. You can see that there's markedly more FSH than LH in the first half of the cycle, and that estrogen, the gold line, is starting to slowly increase as more follicles are being formed under the effect of FSH and more estrogen is thereby being released. Now, in a mature menstrual cycle, there's a positive feedback loop in the first half of the menstrual cycle. The more estrogen that you're secreting is going to eventually cause a mid-cycle LH surge. So there's a positive feedback loop between estrogen and LH, and the more estrogen that you make, it sends a signal to your anterior pituitary gland to secrete LH in a surge, essentially saying that under the effect of estrogen, you can see the endometrial lining has grown and thickened because estrogen essentially lays down bricks, as I like to call it, is growing a endometrial lining. It's thickening it from where it was after it shed after the period of menses. And estrogen is laying down more bricks, creating a thicker endometrial lining. And when there's enough estrogen around, that sends a signal to your brain to say, essentially, the endometrial lining is ready for implantation. It is ready to receive an embryo. The endometrial lining is thick enough. The LH spike is what will cause the dominant follicle, which has developed throughout the first half of the cycle, to release an egg. So one of the important things that happens in the first half of the cycle is that as there's FSH increasing and estrogen is being secreted, there's a negative feedback on FSH. And you can see that the FSH, the green line, is slowly decreasing. A dominant follicle will present itself throughout that first half of the cycle as being the most sensitive to FSH and the one that reacts the best to FSH and has the most FSH receptors. So even with decreasing FSH around, there's one follicle that's really going to thrive in that environment. And it's that follicle that is going to burst and release an egg after the LH surge. Because again, even though there's a negative feedback loop on FSH in the first half of the cycle, there's a positive feedback loop on LH in the first half of the cycle, which leads to the mid-cycle LH surge, which is the spark for ovulation in the middle of the cycle, when there has been enough estrogen around to prime the endometrial lining to receive an egg and eventually an embryo. So that's the first half of the cycle. It's the follicular phase. The second half of the cycle in an ovulatory cycle is when the egg has been released. The egg is now in the fallopian tube waiting for the arrival of a sperm. The shell of the dominant follicle turns into something called a corpus luteum. And I often describe this to patients as the shell of the egg. Once an egg has been released, the shell remains in the ovary and it is called the corpus luteum, and it secretes a second hormone. Remember, in the first half of the cycle, it was secreting mainly estrogen. Once the egg has been released, it's now going to secrete progesterone. Progesterone I often describe as the grout that's laid in between the bricks. So estrogen was all about building and progesterone is all about stabilizing what was built, allowing for a stable, functional endometrium that can really absorb and sustain a implanted embryo. It allows the embryo to stick. We're no longer in a growing phase, which can be a little bit less functional because things can grow at a different rate. As things grow, if there isn't grout around, they can start to shed in a dysfunctional way. So progesterone is all about stabilizing. And the corpus luteum can only exist for exactly 14 days. It has a very, very specific amount of time that it can exist. And the spark for the corpus luteum to stay longer would be the secretion of HCG, which is the pregnancy hormone that would come from an implanted embryo. When there's no embryo that implants, then the corpus luteum never gets the signal to stick around for longer than 14 days, and the corpus luteum is going to spontaneously regress, leading to a withdrawal of progesterone, as you can see at the end of the cycle. The blue line, the progesterone, is going to suddenly decrease as the corpus luteum spontaneously regresses exactly 14 days after it was formed. And that is what's going to be the spark of what causes the shedding in the beginning of the next cycle. That progesterone withdrawal, that sudden drop of progesterone from the regression of the corpus luteum, now you lose all of the grout. There's no more grout around between the bricks, and now the bricks can easily shed, and they'll shed essentially all at once, which causes for a very functional period. It causes for a very coordinated effort for the lining to shed. Now, I want you guys to compare an ovulatory cycle, which is the top line, and you can see this is cutting out a lot of the other lines that we saw in our previous graph, where we had FSH and LH also available. These graphs are only showing estrogen and progesterone, and it's showing in an ovulatory cycle, you have very little progesterone in the beginning, and then you have a lot of progesterone that forms and falls, which is coordinating the menstrual cycle. In an anovulatory cycle, think about that word, anovulation, you did not ovulate. So mid-cycle, you never had that spike of LH to release an egg. No egg was ever released, meaning you never formed a corpus luteum, meaning you never secreted progesterone. So in an anovulatory cycle, you only have FSH, which caused your follicles to develop. Your follicles secreted increasing amounts of estrogen. You never had that mid-cycle LH spike to form a corpus luteum and make progesterone. So then your follicles just kept making estrogen. And eventually you get what's probably an estrogen withdrawal bleed, because again, estrogen is laying down bricks in your endometrial lining, thickening the lining in a dysfunctional way, with no grout ever being laid between the bricks, which can cause the bricks to fall really at any time. So I want you guys to keep that in mind when we later talk about our case and we talk about prolonged bleeding, we talk about dysfunctional bleeding and longer menstrual cycles, where you have a long period of time in between bleeds, because it's an uncoordinated effort when you don't have that progesterone, that corpus luteum body that really exists exactly for 14 days, stabilizes lining, and causes your lining to shed. It's well known that within 2 years of menarche, remembering that the word menarche is the start of the menstrual cycle in the pubertal arch. It's well known that within 2 years of menarche that your periods will most likely be irregular, because the HPG axis is immature. Your body is learning a new language, and this is what I tell patients all the time. For anybody in the audience who's learned a new language, whether that's English, Spanish, French, Arabic, whatever it is, you know that when you first start speaking a language, you make a lot of mistakes. Your grammar is so-so, and your vocabulary is not that broad. There isn't a large breadth and depth to the words that you know how to speak. So you're more likely to make a lot of mistakes in speaking a new language. And I tell patients this all the time. The HPG axis is a new language for your body to speak, and it's oftentimes going to make mistakes. So the interval between starting a period and actually having regular periods is usually around 14 months. And the interval between starting a period and having what's mostly ovulatory periods. And we think of ovulatory periods as being more likely to be painful, since it's that withdrawal of progesterone that calls a lot of prostaglandins to the party to cause the inflammatory state that leads to a coordinated shedding of the endometrial lining. It's usually about 2 years in between the start of periods and the start of consistently painful regular cycles. despite the fact that this is a new language for your body to speak, there still is a consideration of what's a regular cycle for girls who are perimenarchal. We usually say that irregular is regular, but there still is some range that we should consider that's what is worth evaluating. When is it too irregular that as a clinician, you're responsible for evaluating it and finding pathology if pathology is really there. So about 75% of menstrual cycles fall between 21 and 45 days, even in the first year, and still last about 3 to 7 days. By year 5 post-menarche, periods are more likely to be around 21 to 40 days, and 75 to 80% of them will be ovulatory. And in a completely mature menstrual cycle, most periods will fall between 21 and 35 days, and 80% of them will be ovulatory. So it's kind of a slow progression to becoming more regular and more ovulatory. But even within year 1, most periods should fall between 21 and 45 days. So keep all of this in mind as I present to you a case that I see at least once in every clinic. We have a 16-year-old girl who has irregular menses. That's her main complaint when she comes in. She says, I bleed for about 10 to 14 days every 4 to 6 months. I soak through 1 pad per hour for the first 2 to 5 days of my period, and then it goes on to be kind of this prolonged light spotting. She reports minimal pain with her periods, and she also reports acne that's bothersome to her, bothersome hair on her chin and her chest. And she admits that she's really gained a bunch of weight in the past 2 years. She's having a hard time taking it off. She's trying to diet and exercise to the best of her ability, but her BMI is still in the 99th percentile for her height. So in a gynecologic history, we take an inventory of their menstrual bleeding, and we ask, these are common questions that I ask most of the patients that I see. How many days do you bleed for? How many days do you have in between day 1 of one menstrual cycle and day 1 of your next? Do you have any premenstrual symptoms? Any bloating, breast tenderness, headaches, any cramping or pain that predates when you start bleeding? Do you have any pain throughout your menstrual cycle? Is this a pain that keeps you from doing things that you would otherwise doing? Does it respond to ibuprofen or Aleve? How many pads per hour do you use? How many pads do you change throughout the course of a day? Do you have to wake up at night to change your pads? Do you have flooding through your pads? Do you soak through your pads onto your clothes? Do you soak through your pads onto your bed sheets? Are you passing large clots? We're trying to get a sense of if their periods sound normal or if they sound abnormal. We also ask every patient, are you sexually active? Do you have any history of sexually transmitted infections? If you are sexually active and they say no to the history of sexually transmitted infections, I ask if they've also ever been tested. Once we gather that history, we'll also get more history and inventory about this abnormal hair growth that she is describing. Abnormal hair growth on the chin, the chest, the legs, the back, the butt, that's all described as hirsutism, which is an excess in terminal hair growth. This chart that you're seeing is called the Ferriman-Gallwey chart, which describes and is a way that we can clinically quantify abnormal hair growth, giving 1 to 4 points for 9 different body regions, and a score of greater than 14 is considered moderate to severe hirsutism. Acne, which our patient also described, is a multifactorial skin condition that can affect as many as 90% of adolescents. However, I will say that commonality does not mean trivial. Acne has both psychosocial effects, can affect quality of life, self-esteem, and can be associated with other medical conditions. So it's important to put it in an overall clinical picture and determine whether or not it's normal or abnormal and whether or not it needs further clinical evaluation. Our differential diagnosis for patients who have hyperandrogenism, which can be quantified clinically with hirsutism and acne or biochemically with lab testing, is an androgen secreting tumor in the ovary or in the adrenal gland, hyperandrogenism of puberty, which is a normal part of puberty. If you remember in pubertal development, you have breast budding, and then you have pubarchy, which is the presence of pubic hair, underarm hair, and that can really predate your growth spurt and your menstrual cycle. So you do have the presence of male type hormones around before you really have a lot of estrogen around in your system, in your pubertal arch. So you do have pubic hair, underarm hair, which is a reflection of having male type hormones around really before you go through your growth spurt and you eventually develop your menstrual cycles, which is a normal imbalance of male type hormones to female type hormones, which can lead to physiologic hyperandrogenism of puberty. There's also idiopathic hyperandrogenism. Idiopathic just meaning there's no cause for it, but just clinically or biochemically, you have more male type hormones than would be considered normal. Polycystic ovarian syndrome, late onset congenital adrenal hyperplasia, hypothyroidism, hyperprolactinemia, and Cushing's syndrome are all in the differential diagnosis for hyperandrogenism. What we're going to focus on today is polycystic ovarian syndrome, which is defined, depending on the definition that you look at, as both hyperandrogenism plus oligo or amenorrhea or anovulation. In the NIH consensus criteria, both hyperandrogenism and oligo or amenorrhea are required. In the Rotterdam criteria, which are criteria that we also use, it's 2 out of the 3. And clinical or biochemical hyperandrogenism is one of the possible criteria. Oligoamenorrhea and ovulation is one of the possible criteria. The third possible criteria is polycystic ovaries on ultrasound. The Androgen Access Society also gave us a definition, which is 2 of the 3, but it requires hyperandrogenism to be one of the 2 that you select. In adolescence, I will tell you that we typically favor the NIH consensus criteria because polycystic ovaries are very, very common findings in adolescence, and we do not use them as a clinical criteria for diagnosing polycystic ovarian syndrome. So I really use and rely on the NIH consensus criteria for diagnosing polycystic ovarian syndrome in my clinic, and I would argue that most pediatric endocrinologists and pediatric gynecologists are doing the same, and they are not using ultrasonographic criteria to diagnose PCOS. Hyperandrogenism, as we said, can be clinical or biochemical. Clinical, again, being with hirsutism or acne. Biochemical with being elevated free or total testosterone, dihydroandrostenedione, elevated androstenedione, or elevated dihydrotestosterone. Those are all the main androgens that are around in a XX patient, meaning assigned female patient who has internal reproductive organs, who has ovaries as internal reproductive organs and has the possibility of ovulating. We still have circulating male type hormones, and when they're available in excess in lab criteria, that would be also considered hyperandrogenism, even in the absence of clinical hyperandrogenism. Polycystic ovarian syndrome is the most common cause of persistent hyperandrogenism beyond early puberty in adolescent girls. And it's estimated to affect about 10% of reproductive age women. It relates to chronically elevated LH hormone and insulin levels, which leads to increased androgen production within the ovarian theca. Hyperinsulinemia can be implicated in the cause of PCOS, and it not only prevents ovulation and leads to excess male type hormones being secreted from the ovary, but it also suppresses hepatic production of sex hormone binding globulin, which is supposed to bind most of the testosterone in our bodies, leading to a very low percentage of free testosterone that's able to act on testosterone receptors in the pilosebaceous glands. When there's less SHBG, there's more free testosterone available to act peripherally. I want to take you guys back to the I want to take you back to the graph of the menstrual cycle, and I want you guys to imagine what would happen if we were not able to ovulate, and what would happen to these follicles with the production of excess LH. So in a hormonal environment where there's excess insulin, possibly related to type 2 diabetes, prediabetes, or metabolic syndrome, or genetics, excess insulin is going to prevent the follicles from responding appropriately to FSH. And you are going to be secreting estrogen, but you aren't going to have a dominant follicle present. In the absence of a dominant follicle, you are never going to have that positive feedback loop to cause a spike in LH in a coordinated way. Rather, you're going to have a bunch of follicles making estrogen. All these follicles that are making estrogen without one follicle becoming a dominant follicle is going to prevent that mid-cycle LH surge. Instead, there's going to be a constant positive feedback to LH. So you're going to have chronically elevated LH. Chronically elevated LH is going to cause the theca cells to secrete male-type hormones like testosterone, dihydrotestosterone, DHEA, DHEAS mostly comes from the adrenal gland, and androstenedione. That chronically elevated LH is going to cause the ovary to secrete a lot more androgens than what can be aromatized by the granulosa cells, because FSH is negatively inhibited by the presence of estrogen. So your FSH is going to be a lot lower than your LH. And your LH is going to be making all these male-type hormones that your FSH and granulosa cells can't keep up with. So your ovaries are going to be secreting a lot more androgens than they should be. And remembering that the estrogen that's around chronically is going to cause the endometrial lining to grow without the grout ever being laid down from the effective progesterone. And without the grout ever being laid down and the progesterone spiking and then dropping, you're never going to have a coordinated shedding of your lining. So to go back to this slide, try to keep all of that in mind as we go through and talk about the clinical presentation of PCOS. Chronically elevated LH and insulin levels lead to increased androgen production from the ovarian theca. In addition, that elevated insulin is also going to suppress hepatic production of SHBG, leading to more free testosterone to act on pilosebaceous glands, leading to increased hirsutism and acne. We have to monitor these symptoms or have the presence of them in a longitudinal way for the first 1 to 2 years after menarche before really establishing a diagnosis of PCOS. Because, as we said, acne, hirsutism, and oligomenorrhea might actually be very common findings around puberty because you have more male-type hormones around for a period of puberty that's physiologic. Most of your menstrual cycles are going to be anovulatory in the first couple of years because it's a new language that your body is speaking. So you can have physiologic oligomenorrhea in those first couple of years. I would argue that when your periods are longer than 45 days consistently, and you have any periods that are longer than 90 days, that's worth evaluating and worth doing a full evaluation for possible hyperandrogenism and irregular menses when there's also signs of persistent or refractory acne and hirsutism. Because those things are not common in puberty and they do warrant evaluation. They can be a sign of pathology. I would also argue that treatment of acne, hirsutism, and irregular menses should not be withheld for the first 2 years if it's affecting quality of life and if it's affecting the patient's, psychosocially or their self-esteem or whatever it is, making it hard to go to school because you have random periods, you don't know when they're going to come, and they can be excessively heavy when they do come. Those are all things that do need to be evaluated and do need to be treated. even if you say to the patient and their family, we can't necessarily give it a diagnosis at this point. It's hard to know if these symptoms are going to persist over the long term. These are the things that we can do to treat it. And then we can talk about if we want to take a break from treatment at some point and see if these symptoms persist. So when we have a patient who presents to us with irregular menses and clinical signs of hyperandrogenism, we're going to start with a history. We're going to ask about the age of menarche. We're going to take a menstrual history, asking all of those questions that we just reviewed in terms of the frequency of the periods, the length of the period, and how heavy the periods are. We're going to ask about symptoms of hyperandrogenism and the progression of those symptoms, including both acne and hirsutism. We'll also ask about family history of PCOS and hirsutism, and we'll ask about previous therapies that were tried, both to treat the acne, the hirsutism, or the irregular menses. On physical exam, we'll check a blood pressure, we'll check a weight and a BMI, and we'll also do a skin exam looking for hirsutism, acne severity, acanthosis nigricans, and skin tags. I've referred a lot to elevated levels of insulin, and that's reflective of oftentimes prediabetes, diabetes, or insulin resistance, which can present with metabolic syndromes or pre-metabolic syndromes for patients whose bodies do not process glucose in a normal way, meaning when you ingest glucose, your pancreas sees it, secretes insulin appropriately, but your cells are not allowing the glucose to enter into them with the presence of insulin. So your body is making more insulin, leading to hyperinsulinemia. And that can be very common for patients who carry a lot of their weight centrally, because fat cells in the central adipose tissue, which is mostly carried not necessarily subcutaneously, but actually intraperitoneally or preperitoneally, those fat cells are famous for being insulin resistant. And insulin resistance is a risk factor not only for PCOS, but also for diabetes, hypertension, and cardiovascular disease. So it's an important clinical finding and an important thing to keep in mind when you're evaluating patients. And high levels of insulin can create acanthosis nigricans, which is a darkening of the skin on the neck and under the arms. And I'll show you guys a picture of that on the next slide. After you take your physical exam and you start thinking about what lab testing you would want to order, it's important that you stratify patients on whether or not they have regular or irregular menses. That's a lot of R's in one sentence. And if they have irregular menses, like our patient does, we're going to check FSH and LH levels. We'll check a prolactin, a thyroid stimulating hormone, free and total testosterone, DHEAS, and 17-hydroxyprogesterone. You'll remember that our differential diagnosis included congenital adrenal hyperplasia, androgen secreting tumors, hypothyroidism, hyperprolactinemia. So essentially, the workup of PCOS necessitates that you rule out other potential causes of hyperandrogenism, which is why we're sending off all of these labs. You'll notice that if the 17-hydroxyprogesterone is greater than 200, that is a sign of congenital adrenal hyperplasia, which is a clinical diagnosis that occurs when part of your adrenal gland is not working due to an enzyme deficiency, and that creates an overstimulation of the other parts of your adrenal gland, which can create more androgen secretion from the zona reticularis. And that's called congenital adrenal hyperplasia, which would lead to clinical signs of hyperandrogenism as well as biochemical, and would also cause irregular menses. This is usually something that presents in infancy with virilization and with ambiguous genitalia, but mild forms of congenital adrenal hyperplasia can lead to adult onset or late onset congenital adrenal hyperplasia with hirsutism and irregular menses or anovulation. An ovarian tumor that's secreting testosterone or an adrenal tumor that's secreting DHEAS would have very elevated levels of androgens. And the cutoffs for that you can see in this slide are 200 for the testosterone, 700 for DHEAS, and that would warrant imaging evaluation of your ovary and your adrenal gland, looking for a potential tumor. That would usually present with a very fast onset of hirsutism and acne, would also present with a new onset of irregular menses, and usually present with other signs of virilization, clitoromegaly, deepening of the voice, things along those lines, because those are very high and irregular levels of androgens. PCOS can have, and oftentimes does have, biochemical signs of hyperandrogenism with elevated testosterone or DHEAS, but it would not exceed those cutoff values. This is a picture of acanthosis nigricans in skin tags, which is associated with elevated insulin in the setting of excess central adiposity, insulin resistance, and potentially in the setting of metabolic syndrome with high blood pressure, increased waist circumference, hyperlipidemia, and things along those lines. So for our patient, we do this history, we do this physical, and this is the information that we get from her. Her period started at 14, but she had adrenarche at age 6, and she was born at a low birth weight. There is a very interesting triad, I would say, of clinical findings for patients who have PCOS, that they often had IUGR, intrauterine growth restriction, and low birth weight in infancy. And then they went on to have premature adrenarche at puberty. And then they had a kind of later onset of menarche, or the onset of periods. It's hypothesized that patients who have low birth weight in the uterus are often exposed to elevated levels of cortisol releasing hormone, and cortisol as low birth weight is a stress on the growing infant, or the growing fetus rather. And that stress exposure in utero is going to cause an early activation of the adrenal glands. Early activation of the adrenal glands and an early priming of the adrenal glands to get turned on easily in the pubertal arch is going to lead to premature adrenarche with the presence of pubic hair, underarm hair at an age that's a little bit on the earlier side. Remember, we usually see thelarche be the first thing of puberty, be the first step in the arch of puberty, and it usually starts at age 8. For adrenarche to happen first and to happen at age 6 is abnormal and is a sign that the adrenal glands are primed to release male-type hormones, and that priming can happen in utero, and it's usually associated with a low birth weight. And that's, when you take a history, it's a very common thing that you'll see. It's a very common triad of clinical findings. We also see that her BMI is in the 99th percentile. Her blood pressure does meet criteria for stage 1 hypertension with a diastolic blood pressure of 85. Her waist circumference is in the 99th percentile. Those are all clinical findings that meet criteria for metabolic syndrome. Metabolic syndrome being a syndrome of insulin resistance that increases your risk of cardiovascular disease, but also is the exact hormonal milieu that leads to PCOS. She describes to us acne that's refractory to antibiotic washes that she's tried for several years. She's been shaving her face since the age of 13 and reports that her menses since menarche were always irregular. So she's had 2 years of menstrual cycles, and they've been consistently irregular with cycle lengths for longer than 90 days. Menstrual cycles that last consistently longer than 8 days, those are all things that are irregular and 100% warrant a laboratory evaluation to find potential pathology. So for her, we sent off all of the, we sent off FSH, LH, the androgen levels, and thyroid prolactin, 17-hydroxyprogesterone. And what we found, and I didn't write this, is that her LH is 15 and her FSH is 3. So FSH is pretty suppressed and her LH is very elevated. So there's the LH to FSH ratio is greater than 4, which is not diagnostic of PCOS, but is very suggestive of PCOS. Her free and total testosterone are both elevated, and her androstenedione is elevated. Remembering the NIH consensus criteria for PCOS, this does meet criteria with her irregular menses and her clinical and biochemical hyperandrogenism for PCOS. For patients that have PCOS, especially in the presence of metabolic syndrome, even in the absence of obesity, when you look at age-matched BMI categories, even for patients who have a normal BMI, they are 2 to 4 times more likely to have prediabetes or diabetes and hyperlipidemia. So for all patients who have PCOS and meet criteria, I always send a 2-hour glucose tolerance test, and I always do a lipid panel. So for this patient, I sent both of those things, and her 2-hour glucose tolerance test was notable for an elevated fasting glucose of 105 and an elevated 1-hour glucose of 150. A normal fasting is under 100, and a normal 1-hour glucose is 140. And her cholesterol was also elevated at 220, with normal being less than 200. So what is the treatment for this? We diagnose her with PCOS. We say that she has metabolic syndrome based on an increased waist circumference, plus stage 1 hypertension and hyperlipidemia, and her fasting blood glucose is elevated. So all of those things are diagnostic of metabolic syndrome, and she's diagnosed with PCOS. So what is our next step in treatment? For her, we can certainly talk about diet and exercise. We can work with a nutritionist in order to improve the metabolic environment. I often tell patients that losing just 5 to 10% of your body mass can improve your HPG axis and lead to more ovulatory cycles. So that is considered first-line therapy, is to work with a nutritionist and improve your BMI. I'm very, very, very careful when I talk to adolescents to not focus on the number, and I don't want them, and I certainly don't want anything I say to make anybody have self-esteem issues or feel like there's something wrong with the way that they look. I always tell my patients, ultimately, this is not about how you look or the numbers on the scale. Beauty is in abundance at any size. And I always go out of my way to say that to patients. What I tell them is I'm more concerned about, one, the quality of the food that you're eating and wanting to make sure that you're getting enough vitamins and minerals in your day-to-day diet, and that you are exercising regularly so that your circulatory system is healthy, that you have good blood flow to all of your organs, and that we're improving your metabolic environment, and that we're improving your insulin resistance. And I think of diet and exercise as being both medical therapies to improve insulin resistance, and improving those insulin levels could improve ovulation. So I try to say it in a very, elegant and kind way. And I never talk about, the shape of someone's body or how they look. And especially if somebody reveals, insecurity about it, I go out of my way to really say that, the way that you look is beautiful. And I have no hesitation about you even having the same, like fitting into the same jeans, wearing the same exact clothes. For me, it's about using diet and exercise really to improve your insulin resistance. The second therapy that we can think about doing is if they fail a trial of diet and exercise to improve ovulation, then we can consider using an insulin sensitizing agent like metformin. which improves insulin resistance, can help with weight loss, and can make more of the cycles ovulatory. We can also consider using a continuous oral contraceptive pill or a cyclic progestin if the cycles are not becoming more ovulatory and more regular with our insulin sensitizing techniques. If you guys remember the graph of the menstrual cycle, remember that these patients are under constant estrogen exposure without ever having that progestin exposure. The lining of the uterus, remember, estrogen is laying down bricks. It's growing, growing, growing. Unopposed estrogen for the lining of the uterus is a very dangerous thing because unregulated growth is the precursor for cancer. When we think about the physiology, the pathology of cancer, it's unregulated growth. It's growth that has no checks and balances, and unopposed estrogen, that's what it's doing to the uterine lining. So that is a precursor for cancer. It's a risk factor for endometrial hyperplasia and endometrial carcinoma. And that can occur at any age group with prolonged periods of unopposed estrogen. So we have to think about keeping the uterine lining healthy from that perspective. And having less than 4 periods per year is particularly a risk factor for endometrial hyperplasia in this age group. So we can use cyclic progestins once every 3 months to induce a menstrual cycle if they don't get it on their own. And if they would prefer to have a more regulated menstrual cycle while we work on the diet, exercise, metformin piece. Because like for this patient, her periods were very irregular, but also very heavy when they came. She was changing out a pad every hour for 5 days of her cycle. That's a very heavy period. That's disruptive to your life, to your quality of life. So if she wanted to go on a cyclic oral contraceptive pill in order to have lighter, shorter, more predictable periods, that would 100% be a reasonable thing to do. And remember that oral contraceptive pills have both estrogen and progestin in them. So that presence of progestin is working to both stabilize the lining of the uterus, and then when you have an estrogen progestin withdrawal bleed, then you can shed in a coordinated way. And when you start your next cycle, you have both estrogen and progestin around. So progestin limits the amount that your lining can grow in the presence of estrogen. So it maintains a pretty thin and stable uterine lining that can shed in a pretty functional way. So we can either do cyclic OCPs with a normal cycle or an extended cycle, or we could do cyclic progestins using progestin-only therapy once every 3 months, once every 2 months, once every month, whatever the patient prefers, in order to stabilize the lining that's there. And then when you stop it, you get a coordinated bleed of your uterine lining. The other medication that I occasionally use in this population is spironolactone. And that's really to help with symptoms of androgen excess. So if you guys remember, part of what happens with PCOS is that you're making more male-type hormones, and that's being secreted both from the ovarian theca and from the adrenal gland. Those androgens are able to act in a more effective way on the pilosebaceous glands because less of those androgens are bound to sex hormone binding globulin. With oral contraceptive pills, as they get metabolized through the liver, it actually increases the production of sex hormone binding globulin. So OCPs alone may improve symptoms of androgen excess, especially because some progestins have an anti-androgenic component in their mechanism of action because they competitively inhibit androgens at their receptor. They have a very similar chemical structure, and some progestins act as an anti-androgen in and of themselves. So with the combination of increased SHBG and some anti-androgenic activity, OCPs alone can improve symptoms of androgen excess. But for patients who don't have enough resolution of the terminal hair growth and acne with PCOS, we can consider adding on spironolactone, which is an anti-androgen, as an adjunct to our therapy. I will say that, again, remember that metformin as an insulin sensitizing agent is going to improve some of that as well, since increased insulin is part of this pathology and part of what's leading to androgen being secreted in excess. But for some patients, metformin OCPs alone are not enough. So we can consider spironolactone. Spironolactone is extremely teratogenic. You have to be on a good form of birth control if you are on spironolactone, because if you are carrying a male fetus, spironolactone is anti-androgenic, will suppress the effect of the androgens that are being made naturally in the testes of the male fetus and from the adrenal gland of the male fetus, and will lead to under-virilization of the male fetus. And the male fetus would be born with ambiguous genitalia. So I don't put anyone on spironolactone unless they have a good form of contraception. And then you can also check vitamin D levels in these patients and treat vitamin D deficiency, as vitamin D deficiency promotes insulin resistance and can be an adjunct for treating refractory insulin resistance. And it's a low-hanging fruit. It's a very easy intervention. So I check vitamin D levels in all these patients and I treat vitamin D deficiency. And with PCOS, you'll get a lot of questions when you give a diagnosis of PCOS of what are the comorbidities of this? What are the lifelong outcomes of this? Can I have kids? What does this mean? So what I tell patients is that you meet criteria for PCOS right now, but that does not mean that you will have PCOS for your whole life. And I say this especially to adolescents because we're still gathering information about what their menstrual cycle is going to do over the long term. And knowing that PCOS and insulin resistance are very correlated, I say, with time and diet, exercise, nutrition changes, lifestyle changes, things along those lines, your insulin resistance may improve and your PCOS may resolve. So we don't know necessarily what the life course of this is going to be like. But if you did have PCOS that was untreated over the long term, that does put you at increased risk of having type 2 diabetes, high blood pressure, cardiovascular disease, endometrial cancer, and infertility. Patients get very, very, very nervous. I'll tell you, out of all of those things that you'll say, patients get the most nervous about infertility. I always reassure them that PCOS-related infertility is the easiest type of infertility to treat because we know that you have working follicles and that there are good eggs there. We just have to help them be released. So ovulation induction is very possible with PCOS patients, and they tend to respond very well to Clomid, letrozole as ovulation induction agents. Sometimes respond too well and are at higher risk of having multiple gestations from ovulation induction alone, and also respond very well to ovarian stimulation and in vitro fertilization. So I would say that there's a lot of opportunity for us to treat infertility if you happen to have it. We don't know if you're going to have it. I would recommend to any patient with PCOS to, when you get off of these medications like birth control pills, let's monitor your periods, let's track your ovulation, let's see if you're ovulating using ovulation test kits by checking a basal body temperature, checking a mid-luteal progesterone level. Let's really see if you're ovulating for a couple of cycles. If you're not ovulating, then let's talk about options that we have to help stimulate ovulation. But certainly, there's no reason to worry about that now. And if you're not trying to have a baby right now, let's treat all of these other potential comorbidities of PCOS and then worry about that and cross that bridge when we get to it. And I think that's pretty much it for my lecture. I'm going to be talking about abnormal uterine bleeding in adolescents on October 9th, I think this Friday, and that's actually my last lecture with web shadowers. So I hope you guys can all join that on October 9th. And I'm going to stop sharing my screen and take some questions. So one of the questions that someone asked is an anovulatory cycle what birth control causes? Yes and no. So remember that the anovulatory cycle, I'm actually going to share my screen again. Remember that an anovulatory cycle is under the effect of estrogen only for the majority of the cycle, actually for the entirety of the cycle. If you look at this picture, it's really all estradiol and very low stable rates of progesterone. So birth control pills, yes, suppress your ovaries and suppress them from releasing an egg, and suppress your ovaries from secreting estrogen or progestin, because when you're taking an exogenous estrogen and progestin, that works in a negative feedback loop to suppress FSH, LH, and then your HPG axis is suppressed, and you're providing your body with estrogen and progestin, but you're providing your body with estrogen and progestin continuously. And the progestin is present throughout the cycle, unlike in an anovulatory cycle where there's no progestin. So it actually kind of tricks your body into thinking that you're more in like an early pregnancy or in the luteal phase where you don't have to stimulate a follicle or release an egg because there's already one there. And it suppresses your ovaries from secreting any more hormone, but then gives you back what they're not secreting. So it's anovulatory in the sense that you're not releasing an egg, but it's not anovulatory in the sense that your ovarian or that your uterine lining is just growing, growing, growing without shedding. Next question, what sexually transmitted infection causes irregular periods? So any sexually transmitted infection can cause abnormal bleeding. Mostly it'll be cervicitis and cervical bleeding from kind of damage to the vascularity of the cervix. So gonorrhea, chlamydia are common ones. Chlamydia is more common to affect the cervix, and then gonorrhea is more likely to ascend into the uterine lining and the fallopian tubes and cause salpingitis and pelvic inflammatory disease. But any sexually transmitted infection that can cause cervicitis can cause abnormal bleeding, and can ascend and affect the functionality of the uterine lining. So I tend to check for gonorrhea, chlamydia, trichomonas in all patients who present with irregular bleeding, especially if it's more acute, meaning, they didn't have it from menarche. It's not in the clinical scenario of other endocrinopathies. And if they're sexually active, it's required really to check a sexually transmitted infection panel every year for sexually active patients, especially if they have a new partner. I would recheck it sooner than the 1 year mark. If you cannot afford laser therapy, what are some other ways to decrease hair growth or hirsutism? Hair growth and hirsutism can be treated with supportive management, either using shaving, waxing, depilatory creams, or laser therapy. And then, of course, you want to treat the androgen excess. So in the ways that we were talking about before, either with treating insulin resistance, using oral contraceptive pills, or using spironolactone to block androgens at the receptor, and block the effective androgen at the pilosebaceous unit. That is going to decrease the stimulation for more hair to grow. So it's not going to treat what's already there, but it'll prevent it from progressing. How often do I see ruptured ovarian cysts? I would say that it's not very common. Patients, and this is kind of one of those hard things in medicine where there's no camera inside your abdomen kind of like watching and seeing what happens with these ovarian cysts. And ovarian cyst is a term that's used like a little bit too liberally, because your ovary is designed to make follicles grow, open, and release an egg. And a follicle that grows in a normal menstrual cycle is going to grow to sometimes 2, almost 3 centimeters. And a lot of times, if you get a transvaginal or abdominal ultrasound, they look at your ovaries, they'll see a follicle, dominant follicle that's 2 centimeters, and they'll say, oh, there's this ovarian cyst, which it's not a cyst, it's not a pathology, it's a follicle. But people don't really understand that. And then the radiologist will talk about this ovarian cyst. Then a patient will be like, oh, I have these ovarian cysts. It's not really as common as people think to have ovarian cysts. Occasionally, follicles can grow in a dysfunctional way, and you can have physiologic follicular or pathologic follicular cysts that are greater than 3 centimeters. They can grow up to 10 centimeters, where you have a follicular cyst that is unilocular, filled with fluid. Nothing looks pathologic about it. It's not neoplastic in the sense that it's, an additional growth on the ovary. It's just a follicle that overgrew. So occasionally those can rupture, and that can cause quite a bit of pain, but it's hard to know when that happens, because if someone comes in with pain and then their ovary looks normal, could there have been a cyst there that ruptured? Possibly. And that's especially if there's free fluid in the abdomen. We say like, yeah, it's possible that this could have happened, but I'm not really even sure we know how often it happens. And it's something that sometimes will get overcalled in ERs when people come in with pain and then they're a woman and they have ovaries. They'll be like, oh, maybe I had an ovarian cyst that ruptured. And you know what? Maybe they did. But I would say that it's not that common. How can you differentiate from someone who comes from a region where body hair is common and hirsutism is common? That's a great question, and I think that that's a really important component of your history, is to ask, do other members of your family have this? Especially like I'll use my South Asian or Middle Eastern patients as an example. It's very common to have hair growth on the chin or the sideburns, the chest, the upper buttocks. That's not an uncommon finding. So I would both look at the quality of the hair, if it's more terminal hair, meaning it's thicker, it's curlier. And I would also look at the overall clinical scenario. Is it associated with irregular periods or not? If it's not associated with irregular periods, it's more of a finer hair, it's common, runs in their family, I would think that that's more likely genetic and related to ethnicity. And that's probably more of like an idiopathic hirsutism that's related to ethnicity and genetics. Question of, is there a genetic component to PCOS? Absolutely. PCOS is similar to type 2 diabetes, where there's a strong familial component to it, and probably relates to heritability of insulin resistance and heritability of type 2 diabetes, obesity, things that are both nature and nurture, that you can grow up in an environment where those things are common because of lifestyle habits, and you can also have those things related to genetics, actual genes that were passed down from one generation to another. And there's definitely a familial component to it, both genetic and environmental. How do I handle minors whose parents refuse to allow treatments that use birth control? That's a great question, and something that comes up commonly. And I would say that I explain very similar to what I explained to you guys in terms of the risk of unopposed estrogen and what PCOS does to the lining of the uterus. And I also explain what chronic LH stimulation to the ovaries does to the ovaries with the secretion of excess androgens. And I talk about the way that combined estrogen progestin pills work to treat both of those things. And I actually caution from using the word birth control pills, because if I'm not using it as a contraceptive, I say combined hormonal medications that combine both estrogen and progestin. And I compare that to the efficacy of cyclic progestins, which I feel like a lot more parents are comfortable comfortable using a cyclic progestin, using something like medroxyprogesterone, 10 milligrams a day for 10 days, once every 3 months to incite a withdrawal bleed. A lot more parents are comfortable with that since that isn't a contraceptive, but I tell them, yes, that treats the uterine lining and decreases the risk for hyperplasia, but it does not give a regular period, does not necessarily make the period that comes lighter or shorter, doesn't provide any predictability, and it's not going to treat androgen excess because you're still going to be under constant LH stimulation of your ovaries and constant estrogen excess of your, or constant androgen excess and stimulation of your uterine lining. So I, really talk about those types of things, and I try to focus on saying that it's a medication that combines estrogen and progestin, and I don't use the word birth control pill. I am very transparent about the fact that this medication can also be used for contraception, but that's not why we're using it here. And I find that when I frame it like that, that the conversation is actually pretty easy. How often do I see development of PCOS after puberty or in the early 20s? Very commonly. PCOS can present at menarche, but it actually probably more commonly has an adult onset because with weight gain, environmental changes, like think about somebody who goes to college and gains, maybe 10 to 15 pounds, exercises less than they used to when they were in high school and on a lacrosse team or something. Slight changes in body weight and composition can really tip the scales into insulin resistance and metabolic syndrome. And insulin excess can develop at any age of life and can cause anovulation and PCOS at any age of life. So, I even see women who develop PCOS in their 40s and 50s. But of course, at that point in time, we're thinking more about perimenopause and the smaller availability of ovarian follicles and some of the dysfunction of coming from that, but it can happen really at any age. And I think that's all the questions. And we've run over by about 10 minutes. So I want to thank everybody for joining today, and I hope that I see you all on October, I want to say it's the 9th, it's this Friday at the same time, where we're going to be talking about abnormal uterine bleeding in adolescence, what's normal and abnormal again for periods in adolescence, and how we treat it, how we manage it, and what are signs and symptoms of potential bleeding disorders in heavy periods that present at menarche. So I think it'll be an interesting conversation, and I hope you can all join us, and I hope everybody has a great day. Anything else, Sophia?
Thank you. Thank you so much, Dr. Elborno. That was a wonderful presentation. We all really appreciate you taking the time to do this, and we look forward to your presentation on Friday. Additionally, thank you everyone for attending this session. As per usual, the forum has been posted in the YouTube chat box and also in our Instagram bio, so you will have 30 minutes from now to complete that. And again, thank you so much, everyone, and thank you, Dr. Elborno.